All right, so we're just going to do a little review on enteral tube feedings. This is from chapter 45 in Potter and Perry. So enteral nutrition or enteral feedings provides nutrition directly into the gastrointestinal tract. So it will either provide it through the stomach or to the small intestines. It is a physiological, safe, and economical nutritional support alternative to oral feeding. So the indications. So tube feedings or enteral feedings is if a patient is unable to swallow or meet all their nutritional needs by mouth. So for example, a patient could still eat, but also get enteral feedings, maybe at night or throughout the day. These patients are typically malnourished or underweight, and they're not able to consume enough calories by mouth to meet their demands. So some of the indications you might see is after surgery, more commonly with gastrointestinal tract surgery, but any surgery could require a possible enteral feeding. Trauma, a severe lengthy illness, or a lifelong condition, something that has occurred since birth. To get an overall glimpse at indications for enteral feeding, take a look at page 1075 in Potter and Perry, box 4511. So again, enteral feedings, tube feedings can be used short-term or they can be used long-term, sometimes for the remainder of somebody's life. So the types of enteral tubes. So the main types of enteral or feeding tubes include a nasogastric tube, gastrotomy tube, or a jejunostomy tube. So sometimes you'll see them referred to as an NG tube, a G tube, or a J tube. Nasogastric tubes, or an NG tube, are temporary, usually less than 4 weeks, whereas other tubes can be placed long-term. There are typically 2 types of NG tubes. There may be more, but for this lecture, we're just going to talk about these 2. So the primary one is going to be a Salem sump, and you can use this for enteral feedings, or you can also use it for suctioning. Another one that is strictly used for feeding is called a small bore feeding tube or a Dobhoff. And the reason that you can only use it for feeding is because it's very small and it's very lightweight. Whereas if a Salem sump is fairly large, so you can actually suction out of it and feed. So the Salem sump NG tube is what we're going to be practicing inserting in a couple weeks in lab. So they can end in the stomach or the small intestines. Tubes that are placed in the small intestines are for people with a history of aspiration or chronic nausea and vomiting related to delayed gastric emptying. Nasogastric tubes or NG tubes can be inserted by nurses. We just need a physician's order. All other tubes that are placed through the stomach need to be inserted by a physician, usually by a surgeon or a gastroenterologist. Most of the time, this is done down in the endoscopy suite of a hospital, or sometimes in emergent situations, it can be done at the bedside in the ICU. So these are just 2 pictures of specific enteral feeding tubes. The one on the left is actual NG tube. Okay, that would be the one that we put in where it's going to be inserted through the nose and go all the way down to the stomach. And then the other one is a picture of a G tube or a gastrostomy tube. Okay, and this would be more long-term. And that's typically what they look like. Okay. This is a small feeding tube called the Dobhoff. And these we are allowed to insert, and they're only indicated for feeding because they're much more lightweight and flexible, so you can't suction out of them like you can the Salem sump. Okay, enteral feeding. So actually the feeding that we're going to put through these tubes. We use enteral formula in feeding tubes. So some examples include Gevity, Glucerna, or Isocal. So the formula that we use is suggested by a dietitian based on the patient's condition or needs. So, for example, a diabetic patient may receive a different formula than somebody that is underweight and they need increased caloric intake versus somebody who also has COPD. These patients are not going to get tube feedings that have a high carbohydrate intake because usually after the metabolism and the utilization of carbohydrates, it can actually increase CO2 and the pH content in somebody's body. And that's definitely not what COPD patients need. So enteral feedings, we can do it either bolus, like intermittent, meaning that we would go and we would, every 6 hours, we would put some feeding through their tube, or it would be continuous, where it would run by a pump, and that's on the slide, continuously. So risk and complications of feeding include abdominal pain, nausea, or vomiting. And so as a result, a lot of times they can develop aspiration, which could lead, to the pneumonia. And then there's a really high mortality rate with aspiration pneumonia. So some of these patients can acquire sepsis and lead to septic shock. All right, so some nursing considerations with nasogastric tube or feeding tubes. When we insert an NG tube, like we'll practice in the lab, we'll follow a specific process. When we follow this process, one of the things that we'll ensure is that we don't place the tube in the trachea, that it's going down the esophagus. We will always confirm placement prior to using it with auscultation. We will check a pH level of the aspirate that we draw back, and then we'll get a chest x-ray to finish. And those are things that we'll follow up in the lab and you'll watch on the videos from Evolve. We always need to keep our patient's head of bed at least 35 to 45 degrees, whether they're getting bolus feedings or whether it's continuous. We need to measure the gastric residual that's in somebody's stomach who's getting tube feedings every 4 to 6 hours, or at least prior to that bolus feeding or that intermittent feeding. Okay. High residual volumes could indicate delayed gastric emptying, which can lead to that abdominal pain, nausea, vomiting, and aspiration. So a lot of times, all it is we just will pull back on the tube with a syringe just to see the kind of volume that's left in the stomach. So typical standards are if you have greater than 250 milliliters times 2 times that you check it, you would typically stop the tube feeding and let the gastric emptying catch up, and then you would restart. And then another indication would be is if you check it just one time and there's more than 500, you would stop and follow the same process. Thanks.